Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagard. Each week, we break down a few key studies, usually 2 or 3 original investigations and 1 review article, to keep you grounded in the evolving evidence without needing to read every journal yourself. The goal is simple: a calm, clear, clinically useful summary that you can absorb on your way to work or between patients. Today's episode covers 3 studies: a large alternating cluster-controlled trial testing whether low FiO₂ without suctioning can actually improve outcomes during extubation, a randomized controlled trial from the ERJ evaluating whether facial airflow reduces exertional dyspnea and enhances exercise training, and we close with a state-of-the-art review on sarcoidosis, integrating emerging imaging, phenotyping, and treatment principles. As always, this episode is for educational purposes only, not medical advice, and the links to every article we review are available in the description. Let's get started. Published in Critical Care Medicine this month, this large, single-center, alternating cluster-controlled trial asked a surprisingly understudied question: does the way we physically perform extubation affect outcomes? We routinely treat extubation as a reverse intubation, with 100% oxygen and intratracheal suctioning. But both practices have biologic downsides. Suctioning can induce airway collapse and desaturation, and 100% FiO₂ promotes absorption and atelectasis. This trial randomized 3,675 adults to one of 2 strategies: FiO₂ 100% plus suctioning during extubation. The other strategy, with FiO₂ of 35% without suctioning. The primary endpoint was extubation failure, defined as reintubation and/or non-invasive ventilation within 48 hours. Secondary endpoints included individual failure components, high-flow nasal cannula use, PF ratio changes, ICU and hospital mortality, and readmission. The findings were surprisingly directional. The low FiO₂/no suctioning strategy reduced the primary endpoint by 23%, with an adjusted odds ratio of 0.77. The PF ratio after extubation was also significantly higher, with an estimated mean difference of 4.72 kilopascals. The editorial accompanying the study pointed out that this PF improvement, although modest numerically, is physiologically consistent. Avoiding high oxygen fractions reduces atelectasis formation immediately after extubation. It's notable that the trial included a heterogeneous ICU population, including many short-stay cardiac surgery patients, and only 0.6% had COPD, a limitation because COPD is one of the groups most vulnerable to extubation failure. Another limitation was the use of open suctioning, which is known to generate transient airway collapse. The trial did not evaluate closed suction systems. And since the study was done in a single ICU, the authors acknowledged the generalizability challenge. Still, the signal is clear. The performance of extubation, not just the weaning strategy, matters. The trial suggests that avoiding suctioning and using lower inspired oxygen may minimize post-extubation lung derecruitment and reduce the need for rescue non-invasive ventilation or reintubation. From a clinician's standpoint, this study challenges a dogma that's rarely questioned. If you're in a unit where 100% FiO₂ and intratracheal suctioning are standard, this provides strong evidence to reconsider protocol design. The physiologic rationale aligns with practice-changing data from perioperative settings showing similar trends. But I would be cautious in high-risk phenotypes: COPD, airway edema, heavy secretions, groups underrepresented here. For them, controlled suctioning or a hybrid approach may still have value. Overall, this is one of the first high-quality trials demonstrating that the mechanics of extubation can affect outcomes. The data justify revising extubation procedures toward lower FiO₂ and minimal suctioning, with appropriate clinical judgment. Published in the European Respiratory Journal this month, This randomized controlled trial explored whether a surprisingly simple intervention, facial airflow delivered by a small fan during exercise, could meaningfully reduce exertional dyspnea and enhance training in chronic lung disease. The concept is grounded physiologically in trigeminal nerve stimulation, which modulates the perception of breathlessness. The investigators enrolled 23 participants, including 19 with COPD and 4 with interstitial lung disease, randomizing them to exercise training with fan-to-face airflow or standard training without airflow. Both groups completed 5 weeks of supervised treadmill-based constant work rate training 3 times weekly. The primary outcomes were change in exercise endurance time, which basically means the total amount of time a participant can sustain a constant work rate exercise test before stopping due to symptoms. The second outcome was change in ISO time breathlessness intensity using the Emborg CR10 scale. ISO time breathlessness simply means measuring symptoms at the same moment in exercise. Importantly, both groups trained at similar cumulative volumes, so training load was not a confounder. But breathlessness intensity during exercise sessions was consistently lower in the fan-to-face airflow group. That immediate physiologic relief is meaningful in itself. As for the primary outcomes, exercise endurance time increased by 7.2 minutes in the fan-to-face airflow group, while exercise endurance time increased by 8.6 minutes in the no-fan group. The ISO time breathlessness decreased by 2.1 units with the fan-to-face and 1.5 units with no fan. The magnitude of improvement was similar across groups, meaning the fan did not amplify long-term exercise capacity, but it did consistently reduce dyspnea during individual sessions. The editorial perspective emphasized that real-time breathlessness relief, even without long-term exercise endurance time enhancement, is valuable. For many chronic lung disease patients, dyspnea is the primary barrier to reaching adequate training intensity. Reducing that barrier may support adherence and enable higher sustained engagement in pulmonary rehab settings. In subgroup analyses, the fan-to-face group showed reductions in breathlessness unpleasantness and breathlessness intensity, both statistically meaningful. Physiologic variables such as inspiratory reserve volume, residual volume, all shifted in directions consistent with improved symptom tolerance. This is a classic example of a low-cost, low-resource, highly scalable intervention. The mechanistic underpinning makes sense. Trigeminal stimulation modulates central dyspnea perception pathways. While the trial is small and underpowered for hard physiologic endpoints, the symptom-centered outcomes align with prior experimental data. Clinically, this could be implemented tomorrow in pulmonary rehab settings without cost barriers. For patients with COPD or interstitial lung disease who cannot tolerate exertion because of overwhelming dyspnea, facial airflow may unlock their ability to train at meaningful intensity. In short, facial airflow doesn't transform training capacity, but it reduces dyspnea reliably, and that alone can be a powerful facilitator for real-world pulmonary rehabilitation. Published in the European Respiratory Journal this month, this state-of-the-art review provides a modern, clinically meaningful update on sarcoidosis, and honestly, it's one of the most practical summaries in years. The authors approach sarcoidosis not as a single disease, but as a syndrome with multiple phenotypes, variable natural histories, and diverse organ involvement. The review starts with the basics, but in a way that matters for clinicians. Sarcoidosis forms when genetically susceptible individuals develop chronic, dysregulated immune responses, often triggered by environmental or endogenous antigens. This leads to the hallmark, non-caseating granulomas, which can appear in virtually any organ. Pulmonary involvement is most common, but extrapulmonary manifestations are often what drive disability, and the paper emphasizes this early on. A key teaching point is recognizing how unpredictable the disease course is. Up to 2/3 of patients may never need treatment at all, and for them, overdiagnosis and overtreatment are real harms. But a smaller subset develops progressive fibrosis, cardiac involvement, or neurosarcoidosis, all of which can lead to significant morbidity or mortality. One of the most valuable sections is the imaging update. For decades, we relied on scanning chest X-ray staging, stages 0 to 4, but the review stresses that this approach is now outdated. CT-based phenotyping is far more predictive of outcomes. The review outlines several CT phenotypes: peribronchovascular nodules, galaxy or cluster signs, bronchial distortion patterns, mass-like fibrosis, mosaic attenuation due to small airway disease. Each phenotype carries different prognostic implications. For example, bronchial distortion with traction bronchiectasis suggests a fibrotic phenotype with lower likelihood of spontaneous remission. Meanwhile, classic perilymphatic micronodules often correlate with more benign or non-fibrotic disease. The authors also discuss radiomics, which is emerging as a way to quantify texture, density patterns, and structural distortion to identify high-risk phenotypes earlier. It's not ready for routine care, but it's a direction the field is moving toward. The review gives special attention to neurosarcoidosis, which occurs in about 2 to 8% of patients, but is frequently underdiagnosed. MRI with gadolinium remains the cornerstone. Findings are often patchy and involve the leptomeninges, cranial nerves, spinal cord, or hypothalamus. The authors reinforce a practical point. A biopsy is often not feasible in neurosarcoidosis, so the diagnosis relies on neurocompatible imaging plus evidence of sarcoidosis elsewhere. As a reminder for clinicians, neurosarcoidosis can manifest as facial palsy, seizures, chronic meningitis, or endocrine disturbances. It's one of the few scenarios where early systemic therapy, often high-dose steroids plus a second-line agent, is necessary. Cardiac involvement is found in up to 18% of patients at diagnosis when screened properly. The major imaging tools are cardiac MRI with late gadolinium enhancement, FDG-PET, which may show patchy hypermetabolic uptake, and perfusion studies, which may be helpful to detect scarring and ischemia-like patterns. A newer teaching highlighted in the review is that perfusion defect extent correlates more strongly with outcomes like arrhythmia, heart failure progression, and sudden death than FDG uptake alone. That's important because many clinicians focus only on PET activity. The message is, use both modalities and pay close attention to scarring markers. As far as symptoms, there are 2 symptoms that dominate the patient's quality of life. One is fatigue, affecting more than 80% of patients. The second is small fiber neuropathy, affecting anywhere from 33 to 86%. These symptoms can be debilitating but do not track with granulomatous activity. They frequently coexist with sleep apnea, autonomic dysfunction, depression, neuropathic pain, and post-inflammatory dysautonomia. This distinction matters because increasing steroid doses will not help these symptoms and may worsen them. The authors push clinicians to evaluate fatigue more broadly: sleep quality, anemia, medications, deconditioning, autonomic instability, and mood disorders. As far as treatment, the review takes a strong stance. We need to minimize steroid exposure. Prednisone remains first line, but multiple studies now show methotrexate offers comparable improvement in lung function, often with fewer long-term side effects, though it takes longer to work. For refractory cases, the options include methotrexate plus prednisone, azathioprine, leflunomide, mycophenolate, and last but not least, anti-TNF agents, which may be preferred in expert centers. The authors advocate for a risk-stratified approach. For high-risk organs like heart, CNS, eyes, treat early and aggressively. For non-fibrotic pulmonary disease with mild symptoms, monitoring may suffice. For fibrotic phenotypes, tailor therapy and consider biologics early. For fatigue-only phenotypes, avoid unnecessary steroids. To summarize, this review reframes sarcoidosis as a heterogeneous, multi-system disease with distinct phenotypes, rather than a simple granulomatous disorder. The emphasis on CT phenotyping, cardiac screening, small fiber neuropathy, and steroid sparing aligns with where the field is heading. The take-home message for clinicians is as follows. Don't rely on chest X-ray staging alone. Screen for cardiac disease proactively. Recognize that fatigue and neuropathy often require non-immunosuppressive management. Minimize lifetime steroid exposure. And view sarcoidosis as a long-term condition that needs contextualized decision-making, not a one-size-fits-all algorithm. Overall, this review is a much-needed roadmap for how to manage sarcoidosis in a more nuanced, precise, and patient-centered way. That wraps up this week's episode of This Week in Pulmonary and Critical Care Medicine. Thanks for spending a few minutes staying updated. These small, steady reviews really do add up over time, one article at a time, 1 week at a time. As always, everything discussed here is for education only, and the links to all 3 studies are available in the description if you want to explore them in more detail. If you found this useful, consider subscribing or sharing it with a colleague. The more people who stay current, the stronger our clinical community becomes. I'll be back next week with more original research and 1 review article to help keep you ahead of the curve. Until then, take care, stay curious, and I'll see you in the next episode.